co-chairs, Professor Piyush Ranjan, who's here, and Dr. Harish Vijade from our institute to join us.
So, welcome to this chair of vascular liver disease. So, first lecture will be taken by Dr. Sunil Dadich. Thrombophilia work in vascular liver disease.
Good morning, everyone. At the outset, let me thank the organizer of this meeting for giving me this opportunity to speak on a common topic in our day-to-day clinical practice, the thrombophilia workup in vascular liver diseases. So I divide the topic into, I'll tell you some basics about what is vascular liver disease and some coagulation in liver diseases. We'll tell you about what is thrombophilia and thrombophilic disorders, what are the indications of testing in vascular liver disorders, then a flow of workup and a systematic approach, and finally the take-home points. Starting with the basics, the vascular liver disease, as we all know, are liver is highly supplied by the portal venous system. Around 2/3 of blood flows through the portal venous system, 1/3 through the hepatic arteries, and major draining veins are hepatic veins in the IVC. Accordingly, vascular liver disorders are divided into hepatic arterial disorders, portal venous disorders, and hepatic venous disorders. We are not much concerned about arterial disorders because thrombophilia doesn't occur in them. So we will be more discussing about the portal venous system disorders, mainly portal vein thrombosis or EHPVO, hepatic venous disorders, mainly the Budd-Chiari syndrome. If we talk about what is Budd-Chiari syndrome, it's usually a primary thrombosis of hepatic vein or IVC or combined all these two, hepatic vein and IVC. It can be a presentation as acute or chronic, or around 80% of them will have thermophilic disorders underlying, and many of them will have multiple concurrent factors. As against portal vein can occur in cirrhotic as well as non-cirrhotic conditions. It can also be acute or chronic. It has both local precipitating factors as well as the systemic thrombophilia underlying in these conditions. Cirrhotic PVT is usually because of slow flow. Thrombophilia is less likely. Idiopathic non-cirrhotic portal hypertension is a pre-sinusoidal kind of portal hypertension. Thermophilic disorders are present in around 50% of these patients. Among the pediatric population, the neonatal umbilical vein catheterization, sepsis, dehydration are the major risk factors for portal vein thrombosis in infancy. Many pediatric EHPVO patients are idiopathic, but many of them do have underlying thrombophilic disorders. So pediatric guidelines usually recommend to test for thrombophilia in these group of patients. Coming to the hemostasis, basically starts with a tissue injury, and the first step is a platelet plug formation with the help of platelets, von Willebrand factor. There is a formation of platelet plug, which with the release of tissue factor initiates series of cascades, including both extrinsic and extrinsic pathway leading to the formation of clot, the laydown of thrombin and fibrin, formation of clot. This clot will either dissolute with the help of fibrinolysis or the plasminogen secretion from the liver. In some cases, this clot doesn't dissolute and there is a thrombus in progression, and it can lead to complete vascular occlusion. There are changes which occurs in these hemostatic steps in liver cirrhosis, especially because of lateral decreased portal flow leads to stasis that promotes hypercoagulability. The changes in liver sinusoidal endothelial cells because of capillarization, because of increased factor 8 and von Willebrand factor, it increases the platelet aggregation. And the reduction in ADMET TS13 leads to increased microthrombi formation. Liver is the major site of synthesis of these three factors, protein C, S, and antithrombin. And there is reduction in deficiency of these three coagulation factor further alters the hemostasis. Of course, chronic inflammation and endotoxemia also plays a role in liver patients with liver cirrhosis. So in cirrhosis, the hemostasis balance is between bleeding and cholestasis. It affects all three steps, right from platelet plug to coagulation to fibrinolysis, and cirrhosis is thought to be a rebalanced but unstable hemostasis. But it is, in a way, it's a prothrombotic state, which is not usually picked up by the routine clinical test. INR poorly correlates with the thrombin generation and the risk of bleeding. So we should always go for a viscoelastic test tag or OTEM to look for which products are needed in these group of patients. But fortunately, the disorder which we are discussing today, the vascular liver disorders, they have got cirrhosis only at the later stage of the illness. And if you talk about the varicose striatum in cirrhosis, the all three components of varicose striatum are affected from stasis to endothelial injury to the hypercoagulability. So with this some background, I will talk over to thrombophilia. Thrombophilia is basically a tendency to venous thromboembolism due to hypercoagulability, which is very relevant in these patients with primary liver vascular disorders. Now, what is hypercoagulability? Hypercoagulability is a mechanism of thrombophilia. So don't get confused. Thrombophilia is a disease, and the hypercoagulability is a mechanism of thrombophilia. Hypercoagulability means there is imbalance between the anticoagulant factors and the procoagulant factors. It can be physiologic, it can be acquired, and it can be inherited. And there is a whole list of causes of inherited as well as the acquired thrombophilias. We'll discuss few of them. These are the landmark trials done by European Network of Vascular Liver Diseases, one in 2009, the other in 2010, published both in Budd-Chiari syndrome and portal vein thrombosis. And they look for the prevalence of thrombophilic disorders in these two groups of patients. And we have seen the majority of these patients do have underlying thrombophilic disorders, either inherited or acquired in these both the portal vein thrombosis as well as the Budd-Chiari syndrome patients. So these large European NV study prothrombic factors are seen in 84% of patients with Budd-Chiari syndrome, around 42% of patients with portal vein thrombosis. Combination of two, one genetic or acquired, is seen in 46% of Budd-Chiari syndrome, around 10% of patients with portal vein thrombosis. In portal vein thrombosis, the prothrombotic factors were seen in association with local factor in around 1/3, and around 18% of patients with Budd-Chiari syndrome had even 3 risk factors. So based on these two landmark trials, it is very important to study the thrombophilic disorders. Starting with the inherited thrombophilias, there are basically 3 types. Factor V Leiden deficiency, the mutation, prothrombin mutation, and the deficiency of natural anticoagulants like protein C, S, and antithrombin. They confer a baseline venous thromboembolism risk, FVL 5 times more than the baseline, and the prothrombin mutation 3-fold more than the baseline. FEL and prothrombin mutations are overrepresented in non-cirrhotic PVT, but even in cirrhotics, they are more common in cirrhosis who has got PVT compared to the cirrhotics who do not have PVT. These genetic disorders are often act in concert with other trigger factors like the myeloproliferative neoplasm or the local factors. So if you find one, don't stop here, look for the others also. And this is a large meta-analysis published. The risk of Budd-Chiari syndrome associated with factor V Leiden and the prothrombin mutation. And this is the odds ratio of having these mutations in patients with Budd-Chiari syndrome. So the factor V Leiden was significantly increased. The odds ratio is around 6 times more compared to the overall population, whereas prothrombin mutation is less common. This is another meta-analysis for antithrombin factor and the protein C and protein S in patients with Budd-Chiari syndrome. And 9 studies included, and the overall pooled prevalence varies from 2% to around 5.5%. But compared to healthy subjects, the pooled odds ratio of inherited deficiency of these 3 factors varies from around 8 to 18%. But the important thing is these 3 factors physiologically go down in patients with liver disease. So it is not advisable to test these factors in a person, especially if they have an underlying underlying advanced liver disease. Another most important thrombophilic disorders is we need to consider the local risk factor before going for another test for a thrombophilic disorder. These local risk factors can be local compressive, which includes compression because of mesenteric lymphadenopathy, organomegaly, abdominal masses, hydrated cyst, or a valve. Or these could be local inflammatory factors, which could be inflammatory or infective disease of the abdomen, could be anything. Acute pancreatitis, diverticulitis, abdominal surgeries, or following a endoscopic sclerotherapy session. Or it could be a stasis-inducing risk, especially in patients with advanced cirrhosis and portal hypertension or right heart failure leading to slow blood. Whenever you find a local risk factor, it is very important to take a personal and the family history of venous thromboembolism, especially a history of malignancy, estrogen exposure, trauma, embolization, and other chronic inflammatory states. One of the most common thrombophilic disorders seen in clinical practice is myeloproliferative neoplasm. These are the acquired clonal disorders, especially the polycythemia vera, essential thrombocytosis, are the single most common cause of primary blood carry and non-cirrhotic portal vein thrombosis. Even you have a normal blood counts, the occult MPNs are seen in many of these patients. So always consider testing for these disorders in patients with unexplained blood carry or portal vein thrombosis, because many of them will develop MPN later than the thromboembolic or the thrombotic disorders first. So, and confirming diagnosis of this is very important because it has got a major therapeutic implications, like they require lifelong anticoagulation. Also, they require the cytoreductive therapies. In a meta-analysis of myeloproliferative disorder in patients with blood carry syndrome and portal vein thrombosis, around 1,000 plus patients of blood carry and around 850 patients of portal vein thrombosis. The prevalence of MPNs and the JAK2 mutation around 41% in blood carry, 30 and 27% in portal vein thrombosis. Polycythemia vera was more common in BCS than the PVT, and the JAK2 mutation in the absence of hematologic features of MPN seen in around 15 to 20% of these patients. So routinely you should go for JAK2 mutation rather than relying more solely upon the blood CBC findings. So why to test for MPN in vascular liver disorder? Because it's the most common, and JAK2 mutation is seen in most of them. In people who are negative of JAK2 V617F mutation, you can go for exon 12 in these group of patients. And there are now new studies that people, even if you have a JAK2 negative patients, you should look for calreticulin mutation, which is seen in this smaller group of patients. And this should be tested even if your blood counts are normal. The another common thrombophilic disorder is PNH, paroxysmal nocturnal hemoglobinuria. It's a rare acquired clonal disorder causing complement-mediated hemolysis and thrombosis. It has a predilection for splenic vein thrombosis, especially the Budd-Chiari syndrome, and up to 10% they can have thrombosis at unusual sites. The clues for clinical clues for diagnosis of this disease is unexplained anemia, high LDH, the presence of hemolysis, and these patients should be tested for flow cytometry. Identifying PNH is crucial because a complement inhibitor, eculizumab, can be life-saving in these group of patients, and it prevents the further clotting of bloods. How to diagnose this disorder? By phosphatidyl glycoprotein anchored protein seen on blood cells, especially the RBCs, granulocytes, and monocytes, and accordingly you take the decision of diagnosis. In Budd-Chiari syndrome, it is seen in around 1/3 of these patients, so it's strongly indicated, especially if there are no other cause found. In non-cirrhotic PVT or mesenteric vein thrombosis, it is indicated particularly if you don't have a local factor or if the PVT is idiopathic and recurrent. Thrombosis at multiple unusual sites, you should look for PNH. Hemolytic anemia with vascular thrombosis. This is a classical picture of PNH in clinical practice. Coombs negative hemolytic anemia and hemoglobinuria is highly suggestive. So these are the clinical situations where you should test for PNH. So The clues are young patient, hepatic vein thrombosis, no clear prothrombotic etiology, negative JAK2, anemia, thrombocytopenia, elevated LDH, low heptoglobin, hemoglobin urea. The classical setting you should test for PNH. The another common disorder is antiphospholipid lipid syndrome. It incorporates three things. It's the acquired autoimmune thrombophilia, incorporates lupus anticoagulant, anticardiolipin, and beta-2 glycoprotein 1 antibodies. It can cause atypical site thrombosis, including hepatic veins and the portal veins. Because diagnosis of APS mandates the persistent antibodies. If you found today the antibodies are positive, repeat them after 12 weeks to confirm whether these antibodies are persistent, because transient rise in these antibodies can be seen in many conditions. Diagnosis of APS is important because these patients would require warfarin, lifelong warfarin, because these patients, they poorly respond to directly acting oral agents. APS, okay. Oh. APS is seen in around 10 to 15% of blood carry, and non-cirrhotic it is less common. It can coexist with other. I think the main clinical scenario is a young patient, recurrent thrombus, multiple vascular sites involved, and no other thrombophilic cause found. So be tested. Hyperhomocystinemia is a weak, non-specific risk factor. Should be tested only when the other factors are negative. And if you summarize, inherited thermophilic disorders are more common in PVT, and acquired ones are more common in blood carry. And there are other various prevalence of these factors seen in various patients with PVT and BCSL scapes. So to summarize, factor V Leiden is strongly indicated in blood carry. Prothrombin mutation strongly indicated in PVT. These deficiency, homocystinemia, are weak indicated, should be tested lower down. MPN is strongly indicated in BCS. PVT, it is moderately indicated. Phospholipid and PNH are minor and in rare cases with clinical indications. I'll skip this, already covered. So when to test for thermophilia, the JAK2 mutations, PNS flow cytometry, genetic testing can be done at any time. But the testing which are affected by acute thrombus, liver cirrhosis, anticoagulants, lipoprotein C, S, antithrombin SE, APS, APA, and all others should be tested when the person is stabilized or following the discontinuation of anticoagulation. When you test them, the VKA should be held for at least 2 weeks, DOVEC should be held for at least 2 to 3 days, and LMW should be held for 24 hours. You should use the correct blood bottle. This is the most important slide, or the indication of testing thermophilia in patients with liver disorders. Portal vein thrombosis without cirrhosis, no obvious or transient etiology found, then you should test them. In patient with cirrhosis, indication is selective, only indicated in patient with a previous history, family history, thrombosis at unusual sites like hepatic veins, or lab abnormalities suggestive of thrombotic disorders. In patients with Budd-Chiari syndrome, you should test them in all. Because of high prevalence of multiple risk factors, if you find one, don't stop here, look for others. And if you find something abnormal, I think don't hesitate to refer them to a hematologist for treatment. Just a very important workup. Detailed history is important. Personal history is very important. Previous thrombotic events, history of recurrent miscarriages or pregnancy, underlying medical condition, medications, lifestyle factors, family history of thrombotic disorders. And this is the whole list of thrombophilia workup. You have to pick and choose which one to go and which one to go. And there are certain pitfalls. Last 2 slides. This we have already seen in cirrhotics, acute thrombus, heparin induces 30% decline, warfarin induces marked drop. So optimal timing we have already discussed, at least 2 weeks after VKA. And if you diagnose them at the time of acute thrombus, I think low levels need to be repeated after some time. The practical approach is whenever you find a person with acute thrombus, look for local factors. If the local factor is found, look for CBC, high counts, JAK2, cytopenia, PNH. CBC normal, extent of thrombus. If the isolated, go for inherited. If it is multiple, go for JAK2. No local cause found. First, you go for JAK2 and PNH. And then if both are negative, then again depends upon the single or the multiple vesicle thrombosis. So, ladies and gentlemen, thrombophilia is a common in vascular liver disorder, especially the Budd-Chiari syndrome. Test selectively, as I have discussed. Differentiate between venous and arterial, because arterial don't require this workup. Get the timing right. Avoid interfering drugs. So, detailed clinical history and the systemic approach is essential. Thank you very much.
Thank you, sir. We'll have questions at the end. The next talk is by Dr. Charles Panakel from Kochi, and on a very thought-provoking topic: should we start anticoagulating all patients with liver cirrhosis?
Thank you, chairpersons, and thank you, INASL, for the kind invite, and good afternoon to you all. In the next 12 minutes, I will talk on should we be anticoagulating all our cirrhotics should we be anticoagulating all our patients with cirrhosis? So while the slides are getting ready, why the question? Because we know that cirrhosis is the 11th leading cause for death, and currently only etiological treatment and non-selective beta blockers are found to change the natural history of cirrhosis, and that's only treatment modality that can prevent decompensations and further decompensations in your cirrhotics. And we need to have a disease-modifying agent that can alter the natural history of cirrhosis, and we are still in lookout for that. And when we talk about cirrhosis, we know that it's not an autoanticoagulated state. It's a state of rebalanced hemostasis. Your deficiencies of your liver-derived clotting factors are counterbalanced by the excess of von Willebrand's factor, the factor VIII, and the reduction in your natural anticoagulants like protein C, protein S, and antithrombin 3. And many of your cirrhotic patients at the time of stress are in a prothrombotic state. And we have seen that these patients can have normal thrombin generation or even excess thrombin generation, leading to a prothrombotic state where there's an excess thrombin in your hepatic microcirculation. And the thrombin does not act on the coagulation cascade alone. It acts on multiple receptors, especially the protease associated activated receptor, the PR receptors 1 to 4. And these PR receptors are seen in your thrombocytes, it's seen in your sinusoidal endothelial cells, and it's seen in your hepatic stellate cells. So in your hepatic microenvironment, the thrombin that is generated in a hepatic microenvironment, they can stimulate your platelet leading to aggregation, and that can lead to further thrombosis in your hepatic venules and in your portal venules. It can act on your sinusoidal endothelial cells, and through the PR receptors, it can activate the sinusoidal endothelial cells into a pro-inflammatory state, where it secretes more of pro-inflammatory cytokines, and that leads to more inflammation. And it can secrete chemotaxins that can cause migration of inflammatory cells into your hepatic sinusoids. And it can also cause the sinusoids to secrete more of vasoconstrictor substances like endothelin, leading to sinusoidal constriction, and that can lead to more stasis and more increase in your portal pressures. Sorry. And the thrombin also can act on PR receptors 1 and 4 in your hepatic stellate cells, and that can convert the hepatic stellate cells into your myofibroblast. And the proliferation of myofibroblast and activation can lead to excess deposition of fibrous tissue in your liver. So the thrombin that is generated, in the hepatic sinusoids, it can lead to activation of myofibroblast and leads to progression of fibrosis in your cirrhotics. Also, we can see that the thrombosis, or if in a procoagulant state, there can be excess thrombus in your hepatic venules as well as in the portal venules, leading to hepatic congestion as well as ischemia. And there's hepatocyte dropout leading to parenchymal extension, and this is replaced by fibrous tissue. So a prothrombotic state in your cirrhotics, if a cirrhotic that is exposed to stress and leading to prothrombotic state, that can lead to hemostasis in their hepatic venules and portal venules, leading to parenchymal extension as well as leading to fibrosis that can lead to progression of your cirrhosis. And also thrombosis can occur in the microvasculature of your gut, leading to ischemia of your gut and as well as enterocyte dysfunction, making your gut increasingly leaky. That leads to excess bacterial translocation and systemic inflammation, and this can again lead to progression of the progression of your cirrhosis leading to decompensation. And this is a pathophysiological basis why the question has been asked to me that should we be anticoagulating all your patients to reduce the thrombin generation in your cirrhotics? So do we have evidence for that? A lot of preclinical studies based on this pathophysiological basis, and all the preclinical studies on animal models of cirrhosis have shown that using unfractionated heparin or low molecular heparin or your direct acting anticoagulants, it can reduce the fibrosis, reduce inflammation, as well as improve liver functions in the various animal models of cirrhosis. And this is a meta-analysis of all the studies of established animal models, experiment animal models for chronic liver disease, that looked at whether anticoagulation can improve reduce the fibrosis, improve inflammation, and prevent decompensation. And it showed that anticoagulating the cirrhotic animal models of cirrhosis can reduce fibrosis, it can reduce portal hypertension, as well as reduce inflammation. So we have got a good pathophysiological basis to anticoagulate our patients, and we have got a good preclinical evidence. But do we have clinical evidence? And most of the clinical evidence for anticoagulating your patient's cirrhosis come from retrospective studies. And this is a retrospective study by Serper that looked at anticoagulating cirrhotic patients with atrial fibrillation. So cirrhotic patients who had an indication for anticoagulation, who had atrial fibrillation and an indication for anticoagulation, they retrospectively analyzed classified them into two groups. That's the patients who received anticoagulation and patients who did not receive anticoagulation. And they showed that patients who received anticoagulation had a reduced all-cause mortality that was independent of prevention of ischemic strokes and cerebrovascular accidents. So there is something beyond prevention of ischemic strokes and cerebrovascular accidents in your cirrhotics who received anticoagulation. And this is a meta-analysis of patients who received anticoagulation for portal vein thrombosis that was published in JCH in 2023. Again, here you can see that the all-cause mortality was reduced in the patients who received anticoagulation. And then we have the important competing risk individual patient meta-analysis that looked at the specific question: does anticoagulant improve survival in your patient's cirrhosis and portal vein thrombosis? Here, there were 5 studies and 500 patients. Patients randomized to, not randomized, it's a meta-analysis. Patients, one arm received anticoagulation and other arm received no treatment. And the primary endpoint was reduction in all-cause mortality. And the important studies showed that there was significant reduction in mortality in your patients who received anticoagulation. And this reduction in mortality was independent of the severity of the portal vein thrombus, where the portal vein thrombus was recanalized, and but it depended only on the duration of anticoagulation treatment. But mind you, the problem here is that most of the patients, it's a systematic analysis, and most of the studies included were observational or retrospective studies. And the most of the patients who received who did not receive anticoagulation probably were in the severe group. These were patients who were more severe, who had contraindications for anticoagulation, who were higher risk for bleeds, and who probably had a higher MEL score. So we should take this evidence with some caution. And now we have the proof of concept study. That's a study by Villa et al. Using enoxaparin for portal vein thrombus. Enoxaparin to prevent portal vein thrombus and liver decompensation in patients with advanced cirrhosis. This is a prospective study. They wanted to randomize around 100 patients, but they could reach only 70 patients, and they were randomized to receive enoxaparin in one arm and placebo in the other arm. And this study showed that patients who received enoxaparin, there was a significant reduction in improvement in survival. There was a significant reduction in the liver-related all-cause mortality as well as the liver-related mortality. So the enoxaparin caused a significant reduction in the hepatic decompensations in the enoxaparin arm. And further to this, this year we see that we have the Siroxaban study that is published in Journal of Hepatology in 2025. And again, in the study, they wanted to randomize 160 patients but could reach only 90 patients. So they could randomize only 90 patients, and the patients were randomized to receive Rivaroxaban, which is a direct oral anticoagulant, and versus placebo. And the patients were treated for 24 months and observed. And the study showed that there was a significant improvement in mortality in the rivaroxaban arm, and there was significant reduction in hepatic decompensations in the liver-related arm, and there was no increase in the major bleeds in both arms. So the major bleeds were similar in both the rivaroxaban arm as well as the placebo arm. So coming to the question, whom to anticoagulate in a patient with cirrhosis in 2024. So all patients with cirrhosis who have an indication to be anticoagulated, like patients with cirrhosis and atrial fibrillation, with cirrhosis with a venous thromboembolism, they should be considered for anticoagulation after taking into account, after screening for risk of bleeding and taking into account the risk benefits. So all your patients who has got a male patients with a CHADWA score more than 2, or the CHADWA score females with a CHADWA score more than 3, and child A or B, these patients should be considered for anticoagulation, taking into account the risk for bleeding. And patients with child C, ideally, the current guidelines do not recommend anticoagulating for atrial fibrillation, because unless they are candidates for liver transplant because of the high short-term mortality. In patients with portal vein thrombosis, if your cirrhotic patient has got a complete recent onset, that within 6 months they got a complete portal vein thrombus, or a portal vein thrombus more than 50%, and that is extended to SMV, or patient is a liver transplant candidate, or patient has got a symptomatic portal vein thrombus, or a portal vein thrombus less than 50% that compromises the SMV, then these patients should be considered for anticoagulation after taking into account the risk of bleeding. And coming to the question that I have been asked, should we start anticoagulating all patients with cirrhosis? We have good pathophysiological background as well as preclinical evidence, but we need good randomized prospective studies before we can start recommending universal anticoagulation for all your cirrhotics. So what anticoagulant to use? In very sick patients, the latest guidelines has come from the ISTH, that's the International Society for Thrombosis and Hemostasis, and they recommend that in your very sick patients who are admitted, use low molecular weight heparin. Whereas if the patient is not that sick or ambulant patients, in child A and B, you can use DOACs or low molecular heparin or vitamin K agonist, and latest studies have shown that DOAC has got a better bleeding profile compared to vitamin K agonist in your child A and child B patients. In child C patients, you cannot use DOACs, and you need to use either low molecular heparin or vitamin K agonist. So to summarize, your cirrhotics, you should know that your cirrhotics are not autoanticoagulated just because your INR is prolonged or APTT is prolonged or they got low platelets. And anticoagulation therapy should be considered in patients with cirrhosis, and the approved indication for anticoagulation, like patients who need anticoagulation for atrial fibrillation or a venous thromboembolism or a portal vein thrombus. And decision to anticoagulate should be individualized, weighing the risk and benefits, and it should be based on patient-specific factors such as severity of the disease, the transplant candidacy of the patient, and other comorbidities. And every cirrhotic patient with any form of planned anticoagulation, the bleeding risk should be assessed, and prophylactic treatment should be for a variceal bleeding should be established. It can either be a beta blocker or it can be a endoscopic variceal ligation based on the Bavino guidelines. And we need further data from good quality studies before we can recommend anticoagulation for all our patients with cirrhosis. Thank you.
So the next speaker is Professor Amit Goyal, who will be talking about management of coagulation for surgeries and interventions in patients with advanced chronic liver disease. Over to you, sir.
Thank you. Good afternoon, everyone. And I really thank the organizing team for giving me this opportunity. As Dr. Charles told, that hemostasis is maintained with the balance of procoagulant and anticoagulant factors in normal healthy person. But in cirrhosis, initially we learned that the anticoagulant factors were more dominating, leading to bleeding state, actually hypocoagulable state. Then we learned over the years that actually it is a hypercoagulable state, and now we have reached to the balance, that the balance is maintained, but it is much more fragile, it is less resilient. So any small injury to this balance can lead to either hypercoagulation or to hypocoagulation. And so these patients are prone for bleeding condition as well as thrombosis. Bleeding conditions other than the portal hypertension related bleed may be seen during the routine endoscopic procedure, may be diagnostic or therapeutic. Percutaneous common procedures, that the few one I have listed here, which we do most of the time. Intravascular procedures, surgical interventions due to any other reason, or thrombosis in hospitalized patient, particularly in ICU setting, in post-operative status, which could be there in form of portal vein thrombosis or deep vein thrombosis or venous thromboembolism. So overall bleeding risk category, if you take all these procedures, they are categorized in low risk category and high risk category. Overall low risk means the overall risk of bleeding is less than 1.5%, and if it is more than 1.5%, it is high risk category. Endoscopically, specifically, I have given it separately, that the procedure, common procedure which these cirrhosis patient need, which one is the low risk and which is the high risk categories. And these are the two new tests which are available, and we have lots of faith on them. So I summarize the guidelines and the available literature to answer these four questions which are clinically relevant to us, that can these new tests, TEG and ROTEM, can be used to predict bleeding after invasive procedure? Can these tests be used to reduce the transfusion requirement in different setting? And can pre-procedure prophylaxis reduce the risk of bleeding? And small shall venous thromboembolism prophylaxis to be given all the cirrhotic when they're hospitalized, particularly in ICU settings? So I will take them one by one and show the evidence. There are very limited evidence in relation to any of these questions actually. So most of the evidence are, barring few, are related to RCTs, otherwise it is retrospective studies. So if you see here, standard test versus the TEG and ROTEM to predict bleeding and complications. This the three studies RCTs where TEG guided transfusion was given before procedure versus the PT and platelet count, means if PT is more than 1.8 and platelet less than 50, then accordingly transfusion was given, and then the bleeding complication was monitored in this patient. You can see the risk ratio was 0.33, but it was on the either side of 1. So it's the range is 0.01 to 7.87. It is very, very unreliable result. And after this result, actually, this is the one RCT by Dr. Shalimar's group, where the tech-guided transfusion, empirical transfusion means standard platelet and PT-based transfusion, and on-demand transfusion after completion arises. And they have also shown that TEG reduces the unnecessary transfusion, but risk of bleeding is not reduced if we monitor or we plan the transfusion based on the pre-procedure TEG or ROTEM evaluation as compared to our PT and platelet count. So can we use this test to predict bleeding? No, and the same is given by AGA recommendation, that it takes no recommendation because the very limited data is available. BET, viscoelastic test, cannot be used as a predictor of bleeding after procedure. Can we use this test to reduce the transfusion requirement? Means FFP, platelet, or fibrinogen, cryoprecipitate, anything transfusion. So in a cirrhotic patient, these two group of tests, if you use these transfusions, requirement is required when we are planned for some invasive procedure like TJLB, percutaneous biopsy, or anything else, who are presented with varicose bleeding or presented with non-varicose bleeding. So three different settings we will see what data we have. In context of planned invasive procedure, it is the same three study which we had shown in the few previous slide. Again, the risk ratio is 0.37 and on the either side of 1. So very limited data. The total number of participants, you can see 78, including the three studies, very small size studies, very unreliable results, and we need many more data to make any fruitful conclusion. So, for planned invasive procedure, AGA recommends that extensive means TEG and ROTEM is not required to avoid transfusion. This is the only RCT where platelet PT standard investigation compared to TEG and ROTEM was assessed for non-varicose bleeding. From ILBS, this study is there in cirrhosis, single center, triple blind RCT. And all the studies across the board have used the same PTINR more than 1.8 and platelet less than 50,000, and transfusion is given accordingly. Primary outcome measure was quantity of FFP transfused. This was the primary outcome measure. The other things are means bleeding control, rebleeding rate are the secondary outcome. Here we can see that the FFP requirement, transfusion requirement was definitely reduced as compared to the standard test if we are being guided by the TEG or ROTEM, right? But the failure to control bleeding, failure to prevent rebleeding rate, and total hospital length, 5 days mortality, etc., the clinical relevant outcomes were not different between the two groups. If we are bothered, we have facing shortage of transfusion requirement, or we are much concerned about the transfusion, obviously there are issues with the transfusion like trolley and other reactions and availability of the content. So all those things are there, but these are the secondary objective. We need larger studies to make any fruitful conclusion which are oriented toward clinical outcomes. This is the only study. I think this was from AIMS. It was a varicose bleeding, means the comparison of two modalities of investigation to assess bleeding in varicose bleeding setting, single center RCT, and same outcome, same criteria almost. FFP transfusion requirement was reduced, platelet transfusion requirement was reduced, but initial bleeding control was not different, rebleeding rate was not different, and mortality was not different. So both the study have shown the same thing, that the transfusion requirement will be reduced if we are using the newer modalities of investigation, but the clinical outcome will not be affected. But both the studies, these outcomes were the secondary outcome, so we need larger studies with these outcome taken as a primary outcome to make some clinical impression. If we combine the two studies we have just discussed here, again we can see the risk ratio is 0.63, both time it is crossing the 1, so unreliable, very sample size is very small, number of events are so small that very difficult to draw any fruitful conclusion. So with this data we can summarize this section, that TEG or ROTEM guided transfusion does not reduce the need for FFP or PT transfusion in a non-bleeding state, but in a patient, varicose bleeding patient or non-varicose bleeding patient, it will reduce the transfusion requirement. Then third, can pre-procedure prophylaxis reduce the risk of bleeding? We don't have any RCT. We have not even a single RCT. We have all the small retrospective studies where for different indication, we can see these are the number of observational studies of a small size, and their result, their conclusion, evidence is very weak. So these are the recommendations given by different international organizations. ASLD, we can clearly see, is not giving any recommendation for transfusion of FFP or platelet or fibrinogen level before procedure as a prophylactic measure. Society of Intervention Radiology, they are recommending. So most widely accepted thing we can say that platelet count more than 30,000 probably, and fibrinogen level more than 100 is a good, reasonable, safe indicator that risk of complication is less. So venous thromboembolism prophylaxis be given to hospitalized cirrhosis patient or not? We don't have any RCT in this case also. This is the biggest database we have. This is the Danish registry of population-based study where from 1980 to 2005 patient, all those hospitalized patients who developed new onset venous thrombosis, which include portal vein thrombosis, deep vein thrombosis, thromboembolism, they were included, and cases were compared with the control. A large sample size, we can see there almost 100,000 thromboembolic patients and almost 500,000 controls. We can see in all the liver disease patient, whether cirrhotic patient, non-cirrhotic patient, SCC, the risk of thromboembolism was higher. Odd ratio was almost, relative risk was almost close to 2, and this was 2 after adjustment for other important factors. And if we further analyze, unprovoked venous thromboembolism means the risk factor which are well known to induce thromboembolism, like surgery, trauma, surgery, these things. If we exclude those patients, and these are the major factors, even then you will find that the risk of thrombosis is actually increased from 1.74 to 2.06 and 1.87 to 2.1, same way. Means the cirrhotic patients are prone to develop venous thromboembolism, if particularly when we are adjusting the well-known risk factors. So this is the only data we have where the venous thromboembolism prophylaxis in cirrhosis has shown some effect, but again the result is very unreliable. Risk ratio is 1.57. Same thing for the second study. So here AGA suggests standard anticoagulation prophylaxis over no anticoagulation. Means it is recommended that cirrhotic patient, when they are admitted, should be given standard anticoagulation. They should not be treated different because of their well accepted hypocoagulable state, and they should not be kept away from the prophylaxis. So what measure we should, how to identify who should be given anticoagulant in cirrhotic, because we don't have any cirrhosis related specific questionnaire. So these are the standard Padua venous thromboembolism risk assessment. RAM is risk assessment model score. So if scoring is more than 4, we can use we can start anticoagulation. And this is another improved VT RAM risk assessment model. So anyone, whichever is comfortable, or we can compare, this can be used to start anticoagulation, at least in cirrhotic patient, where we, if they are admitted, particularly in ICU setting. So in summary, coagulation balance is very fragile in cirrhosis. It predisposes for both kind of complication, bleeding and thrombosis complication. TEG and ROTEM are not better than traditional test for coagulation to predict bleeding risk following invasive procedures. They may reduce the transfusion requirement in a non-bleeding state, but they reduces the transfusion requirement in actively bleeding state. Right, data are limited on the role of prophylactic transfusion before procedure, and presence of cirrhosis is a risk factor, and we should consider for standard anticoagulation measures, particularly as assessed with these two Padua score and other score-based system. Thank you.
Thank you, Professor Goel, for that excellent talk. I think it was very precise and gave very standard recommendations. I invite any questions from the House. And questions can be asked to all three speakers. Professor Saraswat first.
Thank you, Dr. Madhumita. I think, yes, I would endorse that. All three talks were very nice, to the point, and educative. I have a question for Charles. Charles, you told us about, your question was, should we anticoagulate all cirrhotics? The Siroxaban study that you referred to, it had its limitations, didn't meet the target sample size. Their conclusion was based on a post hoc analysis, but they talked about anti-parenchymal extinction syndrome features, and that by using anticoagulation and preventing parenchymal extinction, you may improve the outcome, and that would be the strongest reason for using it in all cirrhotics, regardless of etiology. What are your thoughts on how important is the parenchymal extinction syndrome in the progression of cirrhosis? That is one. And two, then what ought to be the proper timing? Decompensated CTPC patients, or earlier in the natural history of cirrhosis, maybe just first decompensation or even advanced chronic liver disease? So that's the question.
Thank you, sir. And currently, I don't think we have any data to answer the first part of your question, because even though we know that there's a good pathophysiology saying that thrombin generation can lead to hepatic microcirculation thrombi leading to parenchymal extinction, but we don't have any. I don't think there are any study that has shown a biopsy-proven situation where they have shown that this is what actually happens.
I think the concept of parenchymal extinction is based on the seminal work by Jan Wanless. And if you look at his 2020 paper, he's given a very detailed model of how it is acting based on histopathologic data of explants. He studied explants and then come up with this concept. And yes, the prospective implementation is deficient, but the concept is quite well based.
Yeah, in that study, what he showed is that this subendothelial fibrosis is probably a marker of thrombosis in the microcirculation, subendothelial fibrosis in the hepatic venules and portal venules. So yeah, maybe. And when to implement it, I think it should be done early enough to prevent at least a forced decompensation to have a meaningful impact on your natural history. So it should act like any other disease modifying agents in your IBDs or
In
rheumatology.
the Siroxaban study, they showed benefit only in the CTP7 group, B7.
Yeah, in CTP, yeah. Once it's advanced, I think it will be too late for it to show any meaningful benefit.
So if I can have a quick question to Dr. Sunil. Sunil, you talked to us about thrombophilic disorders in all these vascular liver diseases, but coming to Budd-Chiari syndrome, you basically all the work you spoke about referred to hepatic vein thrombosis.
Yes, sir.
While it may be becoming less, still I think in East Asia, Nepal, some parts like even in Jaipur recently, we had a patient with membranous obstruction of the inferior vena cava. And some Japanese workers have argued that this is remodeling of an IVC thrombosis into a IVC membrane. So what are your thoughts and what are the recommendations for anticoagulation in people with MOIVC?
Actually, sir, as far as the Budd-Chiari IBC alone is concerned, the web is considered as a local risk factor because it has got some abnormalities of vessel wall along with the others. So the thrombophilic disorder should be tested in all because when you have a local, along with the thrombophilic disorder, the chances of progression or the recurrence is higher. They would require a lifelong.
Have there been series of publications on studies on any patient with MOIVC? Whatever earlier data I recall, they were extremely uncommon and they were not, routine testing was not recommended.
Yes.
I think Amit was too clear for me to ask any questions.
Thank you, sir.
Yeah, this is Dr. Apurva from Ahmedabad. The question is for Professor Goel. Is there any data on ROTEM or TEG in transplant patient for reducing transfusion requirement?
No, not for that.
Not recommended.
This is the only data out here.
Okay.
Actually, let us rephrase. That's exactly where we decided to start doing it in hepatology practice because the data came from anesthesiology in transplant and it very much reduces on-table requirement of blood products. And so we took it out of the transplant OT and took it into our ICUs and our endoscopy suites and started using it.
Right.
However, what I would like to point out is what Dr. Goel has been trying to say. Although these are good tests, they're tests in a tube. You cannot match. Most of the bleeding and thrombosis acts via the endothelium. Factor VIII antigen, von Willebrand factor, the endothelium and the cellular component is missing even in TEG and ROTEM. So you can have a bleeding patient with an abnormal TEG or ROTEM.
Right.
You can have a non-bleeding patient with an abnormal TEG or ROTEM. So what is the rationale for correcting a ROTEM or TEG in a bleeding patient when you're not doing the same for a non-bleeding patient?
Right.
The answer simply is endothelial damage. And no amount of coagulation factors or cryoprecipitate is going to compensate for a tear in an endothelial vessel. So the whole idea of a bleeding patient is to correct the site of bleeding. Whether it is variceal, then it has to be the varix. If it is surgical, it has to be the bleeding vessel. The coagulation related bleeding is very little in patients with cirrhosis, and it's the first thing that we need to understand. But I agree with you, as you pointed out, the evidence is really sketchy still outside of the OT settings. So we need to adopt that.
Thank you.
Sir, yes ma'am, go ahead.
I'm Dr. Shweta from Mumbai. I wanted to ask a question to Dr. Sunil. What is your take on testing for thrombophilia in EHPVO patients and do you routinely do it in your practice?
In ESPVO patients, the established portal hypertension adult patient, I don't think there is any role unless there are previous history, a family history, or any other site of thrombosis. In a younger patient, probably it does have a role because then you can always have a second episode, you can prevent it.
So in
But-
all young children who come to us, we should test for thrombosis.
I think we should test for and look for a local factor, the history of umbilical vein catheterization or sepsis or something.
So if there is a local factor like umbilical vein catheterization is present, should we still go ahead and test for thrombosis?
In non-cirrhotic, you may not, but you should. In cirrhotics, you may not.
Thank you, sir.
To Professor. No, I think that the very important thing is that we often encounter in real practice. You're following a patient with decompensated cirrhosis with grossly deranged coagulation tests. All the guidelines say no need for prophylactic correction, and you keep sitting on him. He's listed for transplant 3 days later, and 3 days before that, he has a massive intracranial bleed. So it is not that people with severe coagulation disturbances do not bleed, but simply it is that we do not know how to predict in which ones. And I think that's the basic clinician's dilemma, that you're sitting on a patient with a 5 INR and 30,000 platelets and you're not correcting it. And before he has a critical intervention, you lose the patient. So how does one identify that there is a subset of patients with such severely deranged coagulations who are at risk of life-threatening bleeds? What are the thoughts of the experts and even the chairpersons on identifying this subset in real life?
Answered your own question, sir. The fact that the INR is more than 5 means protein C and protein S is also severely deficient. The fact that the patient is having advanced decompensation means all the endothelium all over the body is inflamed. So that is the risk factor for thrombosis. So these patients can bleed and thrombose at the same time with equal equipoise. So that's the whole issue.
So, I mean, that doesn't really help the clinician.
It's not going to help the clinician. So
knowledge.
I'll actually redirect that question to Dr. Charles. So you have spoken about anticoagulation and you quoted 2 major studies. One is on preventing portal vein thrombosis or preventing hepatic decompensation. So Erica Villa's study with LMWH, and then you had the Siroxaban study with Rivaroxaban. So my question to you is that how many patients have you anticoagulated? And what were your indications for anticoagulating those patients? And what was the subset that you screened before you anticoagulate them?
In my practice, anticoagulation is indicated only in patients who are awaiting transplant who have got a PVT. So any patients who are on our waiting list who develop a PVT, then we anticoagulate because PVT is shown to adversely affect the post-transplant outcomes.
You didn't mention that because that is the most important indication actually in India. It is in a patient who's waiting for liver transplant. There's an eccentric PVT or even a complete PVT. We would anticoagulate those for sure. And that's a clear message that should go out to the audience. If they were not waitlisted for transplant, are you anticoagulating them?
If the patient is symptomatic, yes. If the patient has got SMB
They're
thrombus, yes.
asymptomatic. They're
Yes,
asymptomatic.
If the patient has got a extension of the SMB, yes.
Yes.
Otherwise,
So how many of those have you encountered, sir, and how many have you anticoagulated? Because they're asking you this particularly because this message needs to go out to the audience.
No, at times we see acute portal vein thrombus that is symptomatic.
Acute PVT is an indication. What happens if the patients come with chronic PVT and there's an extension to SMVT?
Again, if the patient is not a candidate for transplant, if the patient's got advanced liver disease, we don't anticoagulate.
So that's the crux of the matter. You can only anticoagulate CTP A, B, C less than 10, which was what the criteria were for Erica Villa's study. And when they did that, they had an RCT. So just 48 patients in either arm. There was 8.8% PVT in the patients who received enoxaparin. Now let's do a thought experiment. The other group is also CTP A, B, C less than 10. There's just 2 patients with CTP 10. And 27% of them develop PVT over the next year. Now let's do a thought experiment. Of all the patients in your practice, you must be seeing 100 patients in a week. Do you see 27% PVT in those who are not getting anticoagulated? Exactly.
That's
Things
a
to be
caveat in
thought
that
about.
study.
All right, and that's in gastroenterology, no less. And coming to the Siroxaban study, they screened more than 300 patients with great difficulty. They managed to muster 98, could not meet their primary endpoint, fair enough, but got published in JHEP because it's from Spain. Do you think that was a particularly great study that we not need to be talking about here? Again, clear message that needs to go out to this audience. This is an INASL. We are Indian scientists. We need to be clear about our patient populations and what we are actually doing in clinical practice. So we are just anticoagulating patients who are waiting for transplant, acute PVT, acute on chronic, extension of PVT, symptomatic PVT, or those with thrombophilia. I hope everybody in the audience has got that clear message. Please read between the lines when you see Western literature and be proud of data from India. And I'm really happy Dr. Goel put out very clear messages on each situation so that people are clear about what we are doing.
So
Can you comment about how many patients develop PVT? He's done a lot of work on it.
So no. So I wanted to ask about the anticoagulation after tips because I'm an intervention radiologist. So
So I think we are moving away from anticoagulating after the tips.
tips, yes.
At the most, we give ecosprin.
Yeah, so
that's
we are also following that. So after the tips, if we are doing tips with PVR, then only we anticoagulate.
Right.
Otherwise, and if the patient is having butt cherry as per the indication or underlying etiology. So we do see many. And is there any relation with the COVID vaccination and the PVT? Do we encounter any patient with no etiology but has vaccination? But everybody.
I had seen one where the after COVID vaccination patient had developed not the venous thrombosis but coronary artery thrombosis. Immediately he was taken
I
for
think
angio.
we had one patient. But there was no etiology in the.
No, but this is the what he was asking that anyone else. So immediately within 30 minutes he got coronary artery. Maybe you don't know. But fortunately, it was done within the SGPG actually vaccination, so patient survived.
yes. So to Professor Goel, sir, so we don't know exactly what really helps in pre-procedural prophylaxis. If we take away, you've shown that non-transplant settings, you have shown the evidence. It's like it doesn't work, whatever we have. But end user who is in practice, still we have 3 society recommendations: ASLD, AGA, and intervention radiology. They gave some recommendation. At least 2 of them gave some recommendation. So like common procedures like hernias or dental extraction, cataract, whatever. Can we follow any of these 3 randomly? What is done exactly in your institute?
See, we are very good in all these things. Whichever suit us, we start following that guideline. If we are comfortable in transfusion, then we will follow the international transfusion. Otherwise, we will follow ASLD, everything. If we are happy, if somebody would have given 50,000, we have started following that. So actually, I don't know what to do. What I believe that most of the literature is telling that platelet more than 50,000 is comfortable. INR up to 1.8 is comfortable. So probably that is what I will take. Even if somebody is having 30 to 50,000, I will not go for a procedure without transfusion. I am accepting it in open forum, whatever be the guideline, because all these guidelines are not based on strong data. What they can change their guideline after 3 months, but patient will go forever.
Urgency of the procedure. Urgency of the procedure.
Urgency, then whatever is available you have to transfuse. Otherwise, if procedure is more urgent, then you have to follow urgency first. ABC will remain the same.
So we thank all the speakers for very nice presentations and a very thought-provoking discussion, and we close this session. Thank you.